I'm very excited to introduce our next speaker, Dr. Eddy Lang, who's here from Calgary, and he's a professor of emergency medicine at the Cummings School of Medicine. He served as the Zone Clinical Department Head at the Emergency Strategic Clinical Networks as Scientific Director for the past decade, completing these roles in 2024. He is known for his contributions to evidence-based medicine. Dr. Lang serves on the Canadian Task Force on Preventative Health Care, where he plays a pivotal role in developing national guidelines that promote high-value care and reduce overdiagnosis. Dr. Lang is an advocate for minimizing harm and low-value interventions. He is internationally recognized for his research and leadership in addressing overdiagnosis and promoting judicious healthcare delivery. Dr. Lang has expertise in applying the GRADE methodology for clinical practice guideline development, contributing to clinical practice improvements across emergency medicine departments and beyond. As a thought leader, he combines academic excellence with a commitment to enhancing healthcare quality and sustainability. Today, he is joining us to share with us adult emergency and urgent care perspectives. Let's welcome Dr. Lang.
Thank you so much, Kasia, and a huge thank you to Beaumerieux and the organizing committee for inviting me. It's been an absolutely eye-opening day. I think this may be one of the first times that you have had an emergency physician come and present at this symposium, so really thankful and honored to be here. And I'm not just here to tell you about low-value infectious disease care. I have also taken it upon myself to find out where the 2 automated defibrillators are on this floor. So in the event that there is a cardiac arrest, be rest assured I will be right on it with help. And I'm sure many of you can help me. So I first want to bring you good wishes from Calgary. And is it... Whoops. So yeah, so beautiful city of Calgary, you're all welcome anytime. We've got mountains, we've got rivers, and we've got some exciting developments in the healthcare system that I'll tell you about later on in this presentation. Just want to be forthcoming with my disclosures. Some of them were already mentioned. I do guideline methodology work with the WHO and other organizations, and I've received an honorarium and travel support to come to this meeting. I should tell you as well, I do not have specific expertise in AMR or infectious diseases. In fact, I only got a 61 on my ID exam in medical school, so I thought you should also need to know that. So let me paint a picture for you. You can't really almost look at the news these days without seeing stories about the emergency department. And the reasons for that are manyfold, and they actually affect antibiotic issues and infectious disease care in the emergency department. So what we're seeing is that because of a lack of inpatient beds for the most part in many Canadian cities and actually across the world, patients who are awaiting a bed upstairs are occupying a significant amount of resources and space in the emergency department, and that's preventing us from bringing in new patients to be seen. And that's why you're seeing primarily these really long wait times. And if you come to the emergency department, you get a triage score. If you're coming in with a bad chest cold or urinary symptoms, you're only going to, CTAS-1, you're going to be seen within minutes. But if you're coming in with infectious disease symptoms, like a fever, or if you're otherwise stable, you're going to get a category 3, which means you could be waiting 8, 9, or 10 hours before you get to see a physician. And after that long wait, just imagine what some of the expectations might be in patients who have come to the emergency department with their infectious symptoms, thinking, my friend got better right away after antibiotics. I need to get antibiotics. And we have to recognize as well that primary care is under strain, and people don't often have timely access to a primary care physician and end up in the emergency department. That's probably the second biggest cause of emergency department crowding, after the fact that sometimes 60 to 70% of all of our beds are patients who are admitted and who just need to find a place upstairs. And we have to just look across to our colleagues in Quebec who are now going to be penalized financially if they don't see 70, 90% or 75% of the patients within 90 minutes. I think that was the estimate. So just imagine the time pressure on emergency physicians in a busy, chaotic environment who are having to make decisions very quickly. And sadly to say, it's sometimes easier to write an antibiotic prescription than to spend 10 minutes explaining to someone why they don't need them. So a lot of these things are going to be familiar to you. I just wanted to reinforce them. Canadians have to unfortunately rely on their emergency departments. We are seeing, over the last few years, going from 14 to 16 million annual visits. I mean, our whole population is only 40 million? So especially in smaller communities, patients have no other option, especially at certain times of the day, than to seek emergency care. And sometimes the belief is that, it's true, I might have to wait many, many hours, but at least what I need to have done and what treatment I need to receive, I will get it in a one-stop shop kind of situation rather than necessarily having to go through primary care. And you can imagine what happens, of course, during viral flu season. We see an incredible upsurge in respiratory complaints, fevers, and infectious diseases as the kids are gathered, as flu season sets in and other issues around crowd gathering take place. So it's gotten to me to be thinking that emergency medicine probably has not put as much effort or thought about this as they should have. And it matters because not only are we responsible for suboptimal prescribing, but we are receiving patients who have had prescriptions given to them on questionable grounds. Obviously people don't always have the luxury of a culture result in the community, and there's many explanations for why this happens, but it's important that we are in tune to this. And antibiotics are honestly, whether it be for the really sick patient who's being admitted to the hospital or outpatient management, antibiotics are amongst the most commonly prescribed medications. And I don't have to tell this audience about the problems associated with misuse. So I think given the huge volume of Canadians who seek emergency care and the fact that the patients who we see are following up in primary care, we could, in theory, play a pivotal role in shaping the prescribing habits of the healthcare community. Not a day goes by where I do not see, of course we'll see the occasional case of C. difficile, but more likely what we see in the emergency department as our population is aging and becomes more frail is that once you're on a course of antibiotics, appropriate or not appropriate, there are always risks and complications. And it doesn't take much to take a 92-year-old who's already taking 2 diuretics and 3 antihypertensives to tip them over with an antibiotic-associated diarrheal illness. So we see this all the time, and it's a major reason for hospitalization, and it's arguably one of the most important consequences of overuse, as are the things listed there. It's not just bad outcomes and poor quality of care, it's costing our system and it's contributing to the strain on inpatient demand. So what are we doing about it? I don't know if this has come up in previous AMR meetings, but a lot of our efforts are channeled through a campaign that we call Choosing Wisely that you might be familiar with. And it's a really interesting program that came about probably about 12, 13 years ago. You've heard of the magazine Consumer Reports, right? That's the same magazine that you're going to use to choose your dishwasher or your sound system. They actually started the movement of making patients and families more savvy consumers of healthcare, and working together with the American Board of Internal Medicine and extending here into Canada, Wendy Levinson here in Toronto, developed this Choosing Wisely project, which is essentially going to each specialty group and asking them to identify 5 things that should be considered more carefully, that should be discussed. It wouldn't be, don't do it. So that's a little bit harsh and dogmatic. It's more like think twice or ask yourself, do you really need to go ahead with this? So the idea is to promote conversations with patients, and tools are provided to help with that shared decision making, and ultimately to improve high-value evidence-based care. So in Canada, we have, through the Canadian Association of Emergency Physicians, invested in the development of the Choosing Wisely list. And I think it's really interesting. I mean, at least this is talking the talk. I'm not sure it's walking the walk. But we have 3 out of our 10 Choosing Wisely Canada recommendations for adult emergency medicine related to antibiotic use. So for sure, we say, probably there's hardly ever an indication to prescribe antibiotics for bronchitis, asthma, or bronchiolitis. It was a common practice, and it's still a bit controversial as to whether you should be giving antibiotics after the incision and drainage of an abscess, which is something that we do daily in the emergency department. And also, for an uncomplicated, low-risk sore throat, as we just saw in that earlier presentation, do not give antibiotics. So at least there's some movement towards stewardship with those recommendations. Less so for the PEDS emergency medicine group, although bronchiolitis was mentioned in the previous slide. But the recommendations here are really about other things for pediatrics. They're about obtaining x-rays and radiographs, and even number 5, which might be a bit controversial, is do not obtain comprehensive viral panel testing for patients who have suspected viral respiratory illnesses. So interesting comment there from the Choosing Wisely pediatric emergency medicine group. And yes, we are going to touch a little bit on kids here. And everything I'm talking about, although I'm an emergency physician in Calgary, relates to urgent cares. Urgent cares see a large proportion of we have a lot of overlap in the patients that we see. Alberta just announced a big investment in new urgent cares with the idea to offload emergency departments. A lot of overlap in the patients, except in urgent cares, you receive very few ambulances and very few patients require admission, although occasionally, maybe once or twice a day, a patient is transferred from urgent care to a regular emergency department. The antibiotic story actually took a more sharper turn in the United States. And in the United States, they've come up with their own Choosing Wisely list, which is even more focused on viral upper respiratory infections, on antibiotic use for viral upper respiratory infections, which seems obvious, but is still a big problem in emergency medicine practice. And then this whole issue, which came up this morning, of obtaining urine cultures. And it's very intriguing to speak to the folks from Detroit about their processes for limiting the number of urine cultures going up to the lab so that we're not diagnosing patients with asymptomatic, or treating patients with asymptomatic bacteriuria and exposing them to the unnecessary risks of antibiotics. They talk about limiting broad-spectrum antibiotic use and not to over-investigate with imaging, because now with these high-resolution CT scans, we can see this little tiny area that's question mark consolidation, question mark pneumonia, and what is the emergency doctor to do in that situation? Obviously, they're going to be feeling obligated to treat, even though ordinarily that's something that would have never come to light or would have probably just gone away on its own. So gladly, these recommendations are not just pulled out of a hat. They're based on careful evidence reviews. They're endorsed by the K board, and they're expert consensus, but they're based on good science and evidence-based methodology, and all of our resources are available on the website. But of course, it's not easy to follow these Choosing Wisely recommendations. There's the time pressures that I mentioned before, the patient expectations, and then although we have the entire province of Alberta, all of the hospitals and urgent cares are on the same electronic health record. So you would think there's a really neat opportunity for audit and feedback and collecting data, and I understand the College of Physicians and Surgeons of Alberta is starting to do some work in this area. But so far, these Choosing Wisely recommendations are kind of hovering in the background, and there's not really a mechanism for each physician to know how they're doing, or to import some kind of accountability mechanism so that we have to show that we are following it when at all possible. And the tools are out there. We can think about things like delayed prescribing or in the audit and feedback. And as I'll mention in a moment, there's a really excellent opportunity to collaborate with our pharmacists to improve antimicrobial stewardship. We also need to think about that at the roots of this problem is, to some degree, the issue of over-investigation. I think we can apply that to unnecessary urine cultures, but it also speaks to the idea of unnecessary laboratory testing, imaging, and discovering things that would have never come to the patient's attention or caused problem had they never known about it, which is essentially the definition of what overdiagnosis is. So I think there's lots of opportunities going forward. We can think about integrating more choosing wisely decision support into the electronic health record and learn from each other, learn from people who are not just, it's not just about hitting the people on the head with a stick if they're over-prescribing, but learn about what the key strategies are of the more appropriate prescribers are and learn from them to help perhaps influence the practice of peers and colleagues. We're doing that already to improve emergency department throughput. There's absolutely no reason why it could not also apply to antibiotics. I'll finish off with the two most exciting things that I think are happening in emergency medicine, infectious diseases. The first one that's evolved over the last few years is, and we're lucky in Alberta, we have dedicated pharmacy support from 8 a.m. to 8 p.m. at each of our 4 big Calgary emergency departments every day. So what the pharmacist's responsibility is to, we do a lot of cultures, blood cultures, urine cultures, and it's not feasible for the emergency physician who ordered them to follow up because they did a night shift, they're gone, they don't have access to their computer. So all of these abnormal results fall to the pharmacist the next day, and they are doing a spectacular job following up these results. So not only are patients who have unexpected positive cultures being contacted and brought back to the emergency department if they have bacteremia, but it also allows the pharmacist to contact the patients who've had questionable antibiotic prescriptions, whose cultures are now negative, and working together with the emergency physician, decide on who could potentially stop, especially if they're feeling much better than they were the day before. So I think this is the model for the future, getting a more systematic, and I think there's a way of doing this in an automated way with our electronic health record, is that if you were prescribed an antibiotic on a Sunday evening, but your urine culture is negative on Tuesday morning, then there must be a mechanism in place where this can be flagged and there's an opportunity to stop an antibiotic early and mitigate the risks that can come with unnecessary or inappropriate antibiotic use and the complications that follow. So that's, I think, one really cool area that it's so exciting to have been part of over the last few years. The other one has got to be the home parenteral therapy programs. Who has home IV antibiotic programs in their hospital for next day treatment? So not that many, but it's a game changer. For years when I was working in the emergency department, we'd see patients going up to the unit, reading magazines, getting IV antibiotics. They looked pretty comfortable. It seemed like a crazy use of an inpatient bed simply because they needed IV antibiotics. So we have a really cool fine-tuned system in Calgary where if we see a patient that we feel needs intravenous antibiotics, they do not get consulted to an admitting service unless they're so sick that they can't go home or they can't ambulate or they can't walk. More likely, we're going to refer them to the next day, and this is 7 days a week, even on holidays, the next day's home parenteral therapy program. So they get their first dose of antibiotics. Sometimes it's Ancef with probenecid to prolong the beta-lactamase effect, or it's a 24-hour dose of what in emergency medicine we call emergicillin. Does anyone know emergicillin? Emergicillin is ceftriaxone. We just give it to everybody when we're not sure. So you get your 1 or 2 grams of ceftriaxone. You're seen by ID the next day. They can review your clinical status. They can review your cultures. They can see what the progression of your infection is. And oftentimes the parenteral therapy is stopped right there. there's diagnostic clarification that occurs, and patients can be well on their way to a safer, less resource-intensive treatment. So I'd love to leave some time for questions. At the end of the day, we have some unique pressures in the emergency department. Despite the huge volumes of patients, I think there's great opportunity to learn and share more about stewardship of antibiotics. Choosing wisely is there, but I think it's under-leveraged, and we probably can consider developing the next 5 recommendations for emergency medicine and think of ingenious and novel ways to get it in front of physicians and to really incentivize its use. And it will also involve a lot of public education because it does take time to explain to someone why, in this particular moment, the risks of giving you antibiotics and the dangers that can fall out from that are actually greater than the potential benefits. And it's ultimately about what matters the most. So these are the main resources that I use and I can direct you to for this presentation. I really appreciate your time, and I'm happy to take any questions in the last few minutes that we have.
Not a question. Okay. 2 years in the Calgary OPAT program in my ID fellowship, excellent program. I think nowadays we are giving PO instead of IV in many of these cases. So then the OPAT is actually kind of an urgent ID assessment clinic, which is still an outstanding idea, and I wish we had it in our center. I agree with you, it's a very efficient strategy.
Yeah, we love it. I mean, if as bad as our hospital occupancy issues are, if we didn't have that as a way to decant especially our soft tissue infections, our borderline pyelonephritis cases, we'd be in a mess. So, I think luckily our financial incentives are aligned. From what I understand, our ID doctors are happy to work there the next day. There's enough of them. There's great nursing support, and there's a pharmacist there, so they really can provide and when they leave the emergency department, they know that they're going to be seen at 8:45 the next morning with a map on how to get to the OPAT, outpatient antibiotic. So if you're not already doing outpatient parenteral IV antibiotic therapies, I would strongly recommend considering it. Great. If there's no other questions. Okay, thanks again.